Okay. Hi everyone. Welcome back to our UKRST SJT series. So we're joined by Dr. Kasai Mahmoud today, who's going to be doing a presentation on the MSRA. So Dr. Mahmoud is a radiology registrar in the Northwest Deanery, so we're very lucky to have him today. So just some ground rules. If we could ask everyone to keep their cameras off and keep themselves muted, um, that would be great. And if you have any questions, please post them in the chat. We'll try and answer as many as we can. And any questions that we don't get around to typing an answer to, we can ask Dr. Mahmood at the end. So, Dr. Mahmood, over to you.
Yeah, thank you so much. Good evening, everyone. This is our third time to meet. So despite the name, it's the SJT, but today we are talking about the SJT and the clinical parts as well. And that was on reflection on the most recent exam in September. So I thought about this exam. I collected very nice feedback. So I thought they really changed a little bit of it. So why not to discuss that with the people? So let's start. So as they mentioned, I'm a radiology ST1 in Northwest. I'm ex-IMT and GP trainee, so it was like a long journey till I got into radiology. So you can expect something like that. If you didn't get it the first time, it's not the end of the world. You should keep trying second, third, and fourth time. So I sat for the MSRA for 3 times before. The first attempt, I scored 519. So my SJT score was 220. Then my second attempt, I studied very hard for 7 months. I scored 560, 250 in SJT, and we will understand what does 250 mean. That's very important. So the third time I scored 630 and 301 in SJT. So I do tutoring now. I do free sessions every month for hundreds of doctors and private course as well. I got very nice, brilliant student who scored high in the last exam. And I start creating like exam-like SJT questions. We will see some of them in this presentation. And I've done one mock as well. So what do we expect in this presentation? How do they score you? That's very important to understand because that will tell us where should we put our major effort. Okay. And the most recent cut-off scores for GP, psychiatry, anesthesia as well, that was from September exam. And the new GMC requirement for the applicant to sit for the exam, they've changed, let's say, very critical prerequisite. And the best strategies to study for the MSRA for the rest of your time and the real examples as well. You will be joined by some of your colleagues who sat for the exam, they scored very high, and they will share their experience with you. Okay, so MSRA assessing clinical reasoning and professional judgment of you across multiple specialty. So if you are sitting for so many specialties, you will need this MSRA. So it's not just for radiology, as you understand. And one of the specialty that you need the MSRA for, of course, radiology, ST1, and nuclear medicine in radiology as a level of ST3, ophthalmology as well, anesthesia, neurosurgery, ST1, ST2, and ST3 as well, and so many other specialties. So what's the MSRA format? You will be examined 2 papers the same day. I'm saying paper, but it's a computerized exam. So you will start by doing professional dilemma, which is the SJT. It is 50 questions exam. 8 of them are pilots, so they are not counting toward your final mark, but you would never know which is which. You got to do all of them. You got to do 50 questions in 95 minutes. And they are of 2 types of questions. One ranking, and the other one is 3 best of 8, as we will see. So the clinical part will follow after 5 minutes break. It's 97 questions exam. 11 of them are pilots question, and you got to do them in 75 minutes. So it's really, it's all about time management, isn't it? Okay, so how do they score you? MSRA scoring is not scored on a percentage. So you are not scoring 90%, 80%, 100%. It's not like that. It ranks you against your peers, the cohort. How did you do in relation to them. And we will see that. So it uses the curve that we all know called the bell curve. Okay, how do they actually score you? Again, if you are talking about the SJT score calculation, there is a partial credit for the near miss answers. What does that mean? If you are ranking questions and you are, for example, keeping A instead of D and D instead of A, they will still score you according to the proximity to the ideal answer. But when we come to the clinical problem solving, the CPS or the clinical part, it is a binary, either yes or no. It is correct or incorrect, 0 or 1. So the marking here is more straightforward. Okay, it's very important to understand how do they mark. So the first step, they calculate the raw mark. What does that mean? So for example, let's talk about the clinical part because it's easier to demonstrate. As we say, there are 97 questions. 11 of them are just a pilot questions. So you will be scored against 86 questions. Okay. So let's say you have had 64 questions correct out of 87. So your raw score now is 64. You have 64 points. How do they do that? How do they process that? Then we'll come to step 2. Using the computer, they calculate the whole cohort, maybe 15,000 applicants. They calculate their raw average and their raw standard deviation. So do they use the whole cohort to calculate the average? The answer is no. They use the middle 68%. We will see that now because they use the bell curve, then they dismiss the outliers, people who scored very, very high and the very, very low. They use just the middle 68%, the people in the middle. They calculate their raw marks. Then from this, they calculate the average of the whole cohort. So let's say the average was 59 and you scored 64, a little bit above the average. Then they calculate on the same time the raw standard deviation. The standard deviation, as we all understand, is a measure of how spread out the score. So if the standard deviation, for example, was 15, that means every 15 marks, there is a new standard deviation, a new part of the curve being achieved. This is the bell curve. Okay, so let's look in the middle. If you can see my cursor here between this 13.59, which is 14%, up to this 14%. When we go down the curve here, this is very important. Let's look at this. So we are talking about the middle here. It's between 15.9% to 48.9. So what do? They collect the raw scores for everyone. Then they saw where the bulk of the people scores. They spotted that against the chart. Then they will take the middle people from 16% up to 48%. These people, they are in the middle. They calculate the average through them and the standard deviation through them. So everyone's standard deviation will take you, for example, from the middle, the exact middle, exact average, up to one standard deviation above, which is 48%, two standard deviation above, which is 97.7%. Again, if you are in the middle and you are scoring one standard deviation less, that means you are going from 50% up to 16%, sorry, down to 16%, then from 16% down to 2.3%. Okay, so they calculate the raw average and the raw standard deviation. And let's say your raw score was 64 out of 86. So how do they use that? Now they calculate something called Z-score. They place you, or Z-score, they place you against the national curve. How do they do that? They take your own raw score and they deduct that from the average. Let's say my own score was 64, okay? The average was 59, as we agreed. So they deduct your score, 64, from the average. So you are above the average by 5 points. These 5 points will be divided by the standard deviation. So they want to know how much standard deviation you are far from the average. I scored 64, which is 5 points above the average. These 5 points equals to 1/3 of standard deviation because the standard deviation was 15. So my score is 1/3 above 1/3 of standard deviation above the average. So my score now is just 1/3 standard deviation, not full standard deviation. It's 1/3 standard deviation. Why? How come 1/3? Because my score is 5 points above the average. These 5 points represent 1/3 of the standard deviation, which is 15. So I'm 1/3 above. Okay, that's very important. Now they take that and they spot that into the mirrored marks. They decided, okay, in our mirrored mark, we needed the average to be 250. They needed that. So anyone who will score just exact average, we don't know the average because it changed every cohort. If you scored just the average, that means you are scoring 250. And the standard deviation would be 40. Their own standard deviation would be 40. Okay. So now they will take your raw score, which is 1/3 above 1/3 standard deviation above the average to spot it on this new mirrored mark. Okay. So if your Z or Z score is 0, that means you are exactly on the average. You are scoring 250 because your Z score is 0. You are moving nowhere from the average. The Z score is how much you move from the average. If the Z score is 0, that means you are exactly on the average. That means your mirrored mark would be 250. If you score 250, that means you are exactly in the average. Okay, if your Z score is 1, that means you are complete 1 standard deviation above the average. So the standard deviation would be, in this case, 40. So that means your score would be 290. Why 290? Because you are 1 complete standard deviation above the average. The 1 standard deviation is 40. So 140 above the 250. 250 is the average. What if my Z score is minus 0.5? That means I scored less than the average by half standard deviation. So my score would be half standard deviation, which is 20 below the 250. The average is 250. So my score would be 230. It works this way. Again, they transform your raw score to the scaled score. How do they do that? They take the Z score, which is how much did you move from the actual average. They times that by 40 and they add that to 250. So in the previous example, my score was 5 points above the average, which is 1/3 of the standard deviation, the actual one, which is here, 1/3. Oh, sorry, 1/3. So they times that by 40 by the mirrored or targeted standard deviation, which is 1/3 of the 40. They added that to the average. So your total score would be 1/3 times 40, which is 10 point something, plus 250, which is the average. Now your total score in the clinical would be 263, which is 1/3 standard deviation above the average. They will repeat the same process with the SJT. And your final score would be the sum of both. So if I scored 170, that means I'm scoring 2 standard deviation below the average because 1 standard deviation is 40. Now I'm scoring 240 is less. So that's why my score is 170, which is very, very less. And if you are scoring two standard deviation less, you will be here. Look at this. This is the average. This is 1 standard deviation less. This is 2 standard deviation less. That means, what does that mean? That means I'm scoring very low. If you are scoring 210, which is 1 standard deviation, why? Because the average is 250. Now you are scoring 40 marks less, which is 210. If you are scoring that, you are scoring 1 standard deviation less. What does that mean? You are better than just 16% of the candidates. Look at this again. If you are scoring, this is the average, you are scoring 1 standard deviation less. So you are on this percentage, 15.9, let's say 16%. So you are better than 16%, but you are less than the rest of the curve. Okay? So it works this way. Again, if you are scoring 250, that means you are moving nowhere from the average. You are scoring 0 in the Z score. If you are scoring 290, this is whole one standard deviation above the average, above the mean, which is very high. You are on top 84%. You are better than 84% of the people. If you are scoring 330, that means you are two standard deviation above the average. Two 40s, 40 and 40, above the average. That means you are better than 98% of the candidates. You are 2%. So why this is important? We'll come to that later. You need at least to be at the average of one of the papers to get into radiology. This is statistically evidenced. If you are less than the average by far, that will be very difficult to you to compensate and to score enough to get into radiology. Okay, so let's have another example. If you are having a very difficult exam, by very difficult, I mean the raw score was 53. The average of the people was 53, which is very less than the previous one. So the average of the people, they are scoring 53. The exam is very tough, a lot of mistakes from everyone. So the average is 53, okay? 53 out of 86. Why 86? This is the scored questions, because 11 of them are just pilot questions. Your score remained the same. You scored 64. However, the average of the people was 53. The average of 2/3 of the cohort was 53. So if we say this 64 was 0.9 standard deviation, it's almost one standard deviation above the mean. Now you are scoring 0.9% of the standard deviation. It's not one complete standard deviation, it's less than that. So your total score would be 286. You are scoring the same raw score. In the previous example, your score was 260, now 286. So it's really not your raw score, it is how do you do in comparison with the average of the people. And I'm telling you, people are studying very hard now, they're scoring very high, especially in the clinical. So you need to be at that level, especially in the clinical. Okay, so let's look at the national statistics. This is the sum of 15,000 applicants. They applied for the GP in February 2025. I'm not talking about September, I'm talking about February 2025. 15,000 candidates. This is their statistics. Look at the difference between the SJT scoring and, the SJT average and marks and the cohort marks in the clinical. Let's look on the left side. This is the clinical part. For example, look at the average. You will see 19% of the cohort scoring between 230 and 250, which is the average. Here, 19% as well, scoring the same thing. That's why it is the average, scoring 250, between 250 and 230. But look at this. How many percentage they are scoring above the average? Just between 250 and 270. In clinical part, 23%, almost 1/4 of the cohort scoring above average, between 250 and 270. On the other hand, when we are looking here, it's just 16% scoring more than 250, less than 270 in the SJT. Okay. How much percentage of the people they are scoring in clinical part more than 270 and less than 290, which is very good score. 20%, 1/5 of the cohort, they are scoring high here. Look how much in the SJT, just 11%. Almost half of them, they are scoring the same marks in the SJT. Again, how many people or percentage are scoring high enough, more than 290 and less than 200 and 310, which is one standard deviation, full one standard deviation, just 9% in clinical. In SJT, they are just 4%. So unfortunately, on the other hand, how much percentage in SJT they are scoring less than 210, which is very low. It is complete one standard deviation less than the average, 18%. You can add this 10% as well. So 28% they are scoring less than 210, which is in the clinical part is just 15%. So I'm trying to say people are scoring very far less in SJT. What does that mean? To get into radiology, anesthesia, ophthalmology, these competitive specialty, you need to work, you need to be as high as people in the clinical, at least at the average in SJT, at least. Okay, so why this is fair, the scaled score, so they are plotting you against the cohort, is not your own percentage, because this standardized the performance across the years, not just if you got a very tough exam this year, and the exam, for example, relatively was easier that year, you are not being mistreated. Now they compare you according to your cohort, so that's why it's fair. So it is always 250 is the average, yeah. So I'm giving you security. The MSRA exam itself, it is 6 to 9 modules. They circulate every day. Let's talk about, for example, the January exam. It's for example 13 days. During these 13 days, they have 6 to 9 modules. These modules circulating every day. So if me and you sitting for the exam on the same day, we might get the same module, we might get different things, but this will keep repeating every day. So why this is important? Because again, the same module will be examined all the time, everywhere. So you should have less fear that I will get some module which is difficult and no one is getting that. So they are keep repeating the same manner, okay? So let's now talk about the SJT part, which I believe it is statistically evidenced more difficult than the clinical part. People are doing less in SJT. So they are examining you in 3 main, let's say, concepts. It's not a concept, it's like themes in SJT. First one is professional integrity. They are assessing how professional you are as generic F2, who understands the GMC, the NHS, and they are examining you against coping with pressure. And this is nothing to do with the NHS and GMC. That's something you will be exposed to everywhere. And empathy and sensitivity. So the questions, the 50 questions of the SJT, they are of 2 types, either MCQs or ranking. They will be around these three concepts. Okay, so we have conducted a post example for the more than 100 doctors. They voted for this is giving us a better explanation, because my personal experience would be different from your personal experience. My weaknesses are different from your weaknesses. So that's why we need to do something systemic, generalized. We need to know why people finding this SJT difficult. So the poll results was showing that 56% of the candidates, that's post-exam and before the results, 50% that are saying the exam was more difficult than expected. And 44% they are saying it was difficult as expected, and 0% are saying it was easier than expected. That's telling us something. If you are going to the exam, you need to be very well prepared. It is free exam, yes, but there are more and more restriction has been going on now. It was free, you can do it whenever, and we will talk about that. There is some restriction being updated now. So you need to be serious about that. I'm telling you, 56% of your colleagues, they worked very hard and they've been telling us the exam was more difficult than expected. 44, they are saying is as expected, and 0% they are saying it's easier than expected. However, we've asked them again, what was exactly the major difficulty? So 54%, that's very important, saying the options were very tricky. We didn't understand what do they mean by that. It's classically the time management is the issue, but in this exam in September, the exam was in September, they've changed so many in SJT style. That's why I'm making this webinar. So, and we will go in depth. So, generally speaking, your colleague saying the problem was that the options is not, the time is not the major issue anymore. However, 31% they are saying we had some time difficulties. We didn't finish on time. We finished just on time. We didn't have time to revise. So 54 saying no, it is all about the tricky options. 31% saying it is about the time. So how should we change our study style? We are going to that as well. So the new SJT style 2025, which I really find that's unfair. But let's talk about that. So brought more scenarios on how to deal with the following issues based on NHS guidelines. First of all, they brought so many questions about feedback. It was not the case before. I've written this exam 3 times. Maybe I hardly had two questions about feedback, but now you need to expect a lot of questions, and I will explain why they are doing that. So many questions about the feedback. Questions about academic activities like audits, presentations, researches. They were there from before, but they are taking more share this time. And the big chunk of the question was about interdisciplinary teamwork. So they're asking you, your colleague said that, what would you do? Your colleague said this to the patient, what would you do? It's all about inter-colleague relationship. They are really focusing on that. So why I think it might not be unfair, because one module of the exam, as I told you, they are 6 to 9, one of them was containing maybe 2/3 of the SJT questions is just about feedback and colleague relationship. Someone is gossiping to you, you gossip to someone. It was just about that. Maybe, let's say, 20, 29, 30 question was just about that. If you are not doing that concept very well, you are losing your exam, unfortunately. So let's look at this from other angle. Why do they do that? Because as I told you, you are at a level. I know most of us are already registrars or working somewhere else. We are not an actual F2. Some of us are F2 as well. So they are challenging you as a generic F2. So they want this potential ST1 or CT1, potential colleague, potential registrar, to understand how to deal with a colleague at this very junior stage of your training. So I think that's why they are talking so much about feedback, about colleague relationships. So you really need to master these concepts. Less frequent questions about receiving gifts from patients. They used to be very, very frequent questions, or dealing with patients' invitations. Less questions about relatives asking about updates for about the patients. They used to be very frequent questions, confidentiality and things like that. They are less frequent now. So you really need to understand that. So after a lot of discussion, feedbacks, polls, we just thought the most common trends that are coming in the exam now, we are talking about more than 6 modules. They are bringing very brief ranking options. It was not the case. If you had a ranking question, usually the stem would be thorough and the options would be very lengthy. Now they are changing that style, tone. The stem would be like 3, 4, 5 lines, but the options are very, very brief. Escalate your whatever, do this. It's just 5, 4 words. So they are really testing your deep understanding. You don't need to talk much. Do you understand what does this option mean or not? Because it will be very, very brief. Again, in one of the modules, they brought very lengthy MCQs options. It was very challenging for the candidates. All of the candidates, they got that module, they were struggling with the time, because they will bring you almost 28 questions ranking and 22 MCQs questions of 50. Those 22, they were very challenging because you need to spend a lot of time reading the stem and reading the options. So get ready for that as well. Again, some of the questions were just reflecting or addressing the new GMC Good Medical Practice. You really need to be aware about that. The GMC Good Medical Practice has been updated in January 2025. In our exam, in January 2025, there was nothing new. Now they updated that. You need to be updated. You need to read that GMC Good Medical Practice, and I'll give you some links for the sources. Don't worry. So let's have practical exam. How do this new trend looks like? If someone could volunteer and read the question, that would be very great. Any volunteer, please?
Yes, I can read.
Yeah, please.
You are F2 on a ward round on busy ward. The registrar is presenting Brit 4. While discussing the patient's social history, the registrar says, well, he's from the southeastern part of the town. You know how those people are with compliance. The remark is clearly heard by the patient, who looks upset, but the bedside nurse, who is from the same ethnic background, looks shocked and uncomfortable. The ward round continues to the next bed.
So they bring you, it's always more than one party, always like that. You, the nurse, the registrar, the patients, always like that. They are confusing everywhere. And of course, in one question, you can tell what the concept is, and you need to know these concepts to answer these questions. So, doctor, would you mind reading the options, please?
Yeah. So I mean the round, pull the registrar aside and say that comment was racist and unacceptable. B, apologize to the patient and nurse for the experience. C, say nothing during the round, privately tell the registrar that the comment was inappropriate. D, reflect on the whole experience. E, during the round, subtly redirect. Actually, the patient's non-compliance is due to language barriers. F, after the ward round, email the registrar supervisor about the comment. G, report the registrar to your consultant in your break. H, document the incident in the patient notes under social history.
This is like typical question in the exam. And we understand one of the concepts here is challenging racism and derogatory remarks, intercolleague relationship, and I need to care about the patient. The patient has been humiliated here, isn't it? So how would we answer? If you want to volunteer to answer this question, that's fine. If you don't want, we can just ask if anyone want to volunteer to answer this question.
I can try.
Yeah, please.
I think A is very good because you're addressing the concern right away, and the ethical principle here, like you said, is speaking up essentially, and even though it's a senior and tackling racism, so A is good. You're stopping the round, you're pulling him aside privately and calling him out. B is also good, although not sure if it's definitely your job to do that, but it's still a good option compared to the others, so I'd still choose B. I think D as well because reflecting is always a good experience and learning from these sort of incidents is good. So I would go for ABD.
Thank you so much. Anyone want to try again? Or are we happy
Yeah,
with ABD?
I have an answer.
Yeah, please.
Yeah, my answer is gonna be B. Apologize to the patient and the nurse for the experience. Then C. Say nothing during the round, and then I'll go to G.
D.
Report to the consultant. Yeah.
D, you mean G.
E, C, and G.
G, okay. Yeah, okay. Very good. Okay. We'll take last trial. Who wants to try? Last one?
I can try.
Yeah, please.
So I think first to speak privately, that would be the best option here, because just to acknowledge what happened privately with the registrar. So I would pick up C, saying nothing during the ward round, and privately telling the registrar that the comment wasn't appropriate. So, and I think the next thing would be I'm not sure, but I don't think stopping the ward round, saying that the comment was racist in front of the patient and the nurse would be the most thing to do. I would say reflect on the whole experience, next best option to say, and maybe the last one. So we choose three, right? Right, and maybe I apologize to the patient and the nurse for the experience.
B, C, D. Okay. So the answer would be shocking. Don't be shocked. But just I'm trying to give you just like a taste of the depth of, and the trickiness of the exam. So now, please don't feel bad or anything, but learn from this experience and take it as a home message and try to change your study this style. Okay. Now, for me, I would rather to just classify the concepts in this question, make it clear in my head, keep that as a habit, then answer the question accordingly. Here, we have intercolleague relationship. I need to support my colleague. He's doing less, but I need to support him. Don't forget that. This is not the most important, but it's easy to pick. The other thing is I need to challenge racism and derogatory remarks. That's something the NHS is applying zero tolerance We all know that. This is very unacceptable. You cannot even think about anything else. Number two. Number three, I'm not ranking them according to the importance. I'm just telling intercolleague relationship, challenging the races, and there is something very important here. So if I could make some hints from the question, I'll start from the beginning. You are F2 in a word round. Whenever, please, if you are doing SJT questions, read every single letter and try to ask yourself, is that something making a difference in the question or not? This is the only way. So you are F2, you are always F2 in the exam, in a word round. Hold on, this is number one. You are on word round. In your head, this is patient safety, patient care. I come from my home every day to attend the ward round. It is my main duty. As F2, I'm frontliner. I need to do the ward round. Ward round means patient care, means patient safety. I cannot mess around with that. So, number one, you have to know where are you. You are in ward round. This phrase is there for a reason. So, number one, this is patient care. I wouldn't say it is immediate patient safety, but it is a patient care. It is a ward round. Keep this in mind. So, the first concept in this question, maintaining patient care, because you are in ward round, number one. It is busy ward, okay? Your registrar, which is SPR, is presenting one patient, discussing the patient, and he is making inappropriate comments. That's well known. Number two, this is not just adding to the complexity, it's not just heard by the patient, it's heard by the nurse, bedside nurse. Okay. What is the hint here? The patient is upset and she is shocked. That means you need to do something about that. You cannot even miss that because they are now affected by this. So the nurse now is not even fit to work. She is shocked. This is constituting direct patient safety. You have to take it this way. If she is shocked and uncomfortable, she cannot carry on her job. You need to address that. Okay? So have patient care. Now let's say colleague well-being, intercolleague relationship, and challenging racism. This question, typical exam question. By the way, I created that question. Don't worry, it's not like recall or anything. So it's carry these concepts. But more important than identifying the concepts is learning the skill. And we are coming to that. Okay. So one of the most important hint in this question is the last line. The word round continues to the next bit. And we will know what is the significance of that. So A, stop the word round. I just saw something. Come on, it is a patient care. Should I stop patient care? Am I in a position to do that? The answer is definitely no. So I cannot stop the word round. Why? Word round is a patient care. Now, if I'm stopping the word round, that means I'm challenging the racism. Okay, that's fine. I must do that. But on the other hand, I'm stopping the patient care. So I have a clash, big clash here between continuing the patient care and challenging the racism. How can I solve that? Because stopping the word down makes sense because I need to stop. I need to challenge that racism. But on the other hand, I should not stop patient care. How can I help that? Who could tell me from the stem which side should we go? Because this is the whole question. Are we stopping the round or not? And it will take you a different direction.
We're not gonna stop it because the round has moved on to the next bit.
What does that mean?
It means we have already moved away from the patient.
Your answer is correct, very, very correct, but I will just give a little bit of help. So the hint here, if the insult and the comment is going on in the continuous, the verb is continuous, he is insulting the patient now, you need to stop everything and challenge that. But be very, very careful and mindful. If the harm has already happened and now you are not stopping anything, you are just challenging for the sake of the concept, but you are not stopping harm, you should prioritize patient care. And it's vice versa. If the insult is going on now, you are hearing and they playing with the word, believe me, they might bring the similar example and telling you, you've overheard the registrar is insulting someone. Here, you need to stop everything and to stop. Why? Because if the patient is being hurt, is being upset, is being, we didn't keep his dignity, he will never engage, there is no patient safety. Now he's insulted. So I need to stop that. I'm stopping the harm first, then re-establishing everything. But now the harm has already happened. You cannot stop it. You need to deal with it as a matter of concept. So now you should not stop the war round. Thank you, doctor. That's good answer. Because the harm has already happened. And this is the skill. This is the difference between skill, learning the skill, and identifying the concept. It's easy to identify the concept, but it's very hard to apply the skill. Here, the skill is, since the harm has already happened, you cannot stop anything. You should not stop the war round. Why? Because you cannot sacrifice addressing the concept and generally over continuing the patient care. You cannot sacrifice that. But if the harm was going on, you need to stop the war round, stop everything, and to challenge that because the harm is being going on. I hope that makes sense for you. So stopping the war round now is a bad option. So A itself is not a good option. You cannot stop the war round while nothing could be done to stop the harm now. The harm has already happened. Okay, so A is not a good option. B, apologize to the patient and the nurse. It's very insulting and they are really upset. You cannot ignore that. They are really upset. It is a fact. They are upset and they are shocked. And you need to recorrect that. So who would tell me why B is not a good option here? It is a shock, isn't it? Why B is not an option?
Because you couldn't apologize on behalf of someone.
I'm not apologizing on behalf, and apologizing, we should just read the exact word. Apologize to the patient and the nurse for the experience. Your answer is correct, by the way, but you need to convince me why.
Because the F2 is not the one who insulted the patient.
No, we should not just apologize for our mistakes. The reason is
Maybe
the
because
say it again.
maybe because it's still going to stop the war round, and I mean, to apologize, we'll have to stop the war round at that time. So it's not saying that later apologize. It's saying apologize to the patient and nurse for the experience. Maybe I don't know.
It's a good observation, but it's not the case because if you are just apologizing in 5 seconds, that is not going to stop the word round. So it is not the case. Yes, Mohammed Usman.
I think it doesn't address the root concern, which is at the end of the day, the registrar.
It does. It is a very straightforward hint. If they are telling you someone is upset, you need to address that. That's a gift. But here, situationally, it's not the good answer.
Because
I
the
will allow
registrar
one
is there?
more try. Yes?
Because the registrar is there, I cannot
Very good.
apologize.
Very good. Very good. If the sinner, the one who did the mistake, was present, you cannot apologize because you will act like you are apologizing on his behalf, which is very inappropriate. You could apologize on behalf of the organization, of the GMC, not GMC, the hospital, the trust, where do you work? But you cannot apologize on behalf of someone verbally or practically. What does that mean? If someone doing something bad and he is there, you cannot apologize. No one will tell you, no book will explain that to you, but you need to analyze questions. Okay.
So can I ask you, if the registrar have walked away, would it be
you
fine to
must
apologize?
definitely apologize. You must.
You must.
Yeah.
So if he have walked away and not in the scene.
Yes,
Okay.
you must. But since he is in the war round, you need to support him, give him the support that he needs to apologize. You cannot apologize on his behalf. On his behalf, as the doctor mentioned, the first doctor, you cannot, if they are phrasing this, apologize on behalf of someone, that's an easy case. But if they made it to apologize and he was there, you cannot do that. Because in the stem, he is there. So you cannot apologize on behalf of someone practically or verbally. Okay, that's why A done, B done. C, what about C? Definitely, automatically, C would be a good option because we are not stopping the war round. We are not addressing something immediately to stop now. So I can address that later on. Say nothing during the war round because it's already, the damage has been done. And privately tell the SPR or the registrar of the committee was inappropriate. Usually, C is very tricky because we don't tend as a junior to speak to our seniors by telling inappropriate. If you could notice that in the foundation paper, whenever there is the phrase, I'm telling my colleague inappropriate, it is a wrong answer because I'm not explaining anything. I'm not giving him why it is inappropriate. I'm not supporting him. You need to tell me, to explain to me, why do you think? I will accept that. So it is very blunt, but here it is very appropriate because there are very certain few things they are inappropriate. We cannot even explain them. Theft, racism, derogatory comments, things like that, you don't need to explain. It's well known, no one tolerates that. So you didn't need to explain. Just tell it's inappropriate. If it was about confidentiality, that's something acquired, you need to tell, oh, you are breaching confidentiality, that's why it's inappropriate. You cannot say it's inappropriate without explanation. But certain few things, you don't need to. That's why C, appropriately, inappropriately. So I will take C, yes, I agree. D, what do you think about D? Is it good or bad? It might not. Yes, Dr. Amina?
Good.
Yeah? Would you take D?
I don't think so.
Why?
Oh, hello? Yeah.
Yeah.
I
I'm
think that
sorry.
it's not proactive, so it's not a proactive approach.
D.
Yeah, so I wouldn't pick it. Reflect on the whole experience.
Okay, that's acceptable, but
I'm not the one who did the insulting, so
no, but you don't reflect on the if you did you reflect on the whole experience, which is something very I would say very proactive. Someone
I
did something
think
bad, and after I address that, then I'm reflecting the whole experience. Why not?
I think it's a
Actually,
good option because it can prevent you from doing similar things in the future.
it's a good option, but why would you tell me in this exact situation D is not a good option? So the answer D is not a good option. I'm making very tricky options just to give you a taste of everything. So why D is a bad option here?
it won't prevent the registrar from doing this in the
The
future.
thing that will prevent the registrar already has been done, which is C. So
Not
why D
addressing,
per se is bad?
not addressing the issue.
No, it's very tricky. But so many questions in the real exam is just like that.
Is
I
it
think because
is it too non-specific?
No.
Is it what you call as fourth best option?
Could be, but that's a very good way of thinking. It might be good option, but not immediately. That's why we keep her as number 4 or 5. That's very safe. But I'm saying I need to learn the concept. In this STEM, D will never be a good option. Never.
Is it because it's a busy word?
Very good. You touched the point. Because now I'm on the word round. When they are giving you an example, they are expecting you to read the STEM and immediately go for that. Imagine yourself in a busy word round and you are leaving the word round and doing reflection. Don't click or activate the clinical sense, the clinician sense by saying, oh, I'm clinician, I'm doing word round, I'm doing reflection later on. Who said that? Be very pragmatic. They are keeping reflect on the whole experience. That means you are reflecting now. They are keeping the phrasing very, very specific. If they are saying, okay, after the word round, do reflection, that's a good option. But they are talking about now you are moving to the next patient and you are thinking about doing reflection now. Does that make any sense? No. You cannot even say stop the word round and ask him to apologize because you cannot stop the patient care, let alone doing a reflection. So the answer D is bad option here because you are in the middle of the word round. Don't assume I'm clinician, I know my role, I will do reflection later on. Did they say that literally? No, that's it. If they kept it after the word round later on, that makes sense. If they kept it like this, that means immediately after reading the step, you are going for D, which is incorrect. So D incorrect. Why? Because you are in the middle of the word round. If they rephrase in a different way that you are doing it later, that will make sense. Why? Look at the number C. Say nothing around. Say nothing during the word round. I'm making very important introduction. Nothing now, but privately. I didn't do that in D. That means I'm doing D right now, which is very inappropriate. That's why A, bad option, B is a bad option, and D is a bad option. You cannot reflect on the middle of the word round. It doesn't make sense. Okay? It's very tricky, but you need to learn that. So C is a good option, yes. E, during the word round, during the word round, okay. Subtly, redirect. Actually, the patient's non-compliance is due to language barrier. What do you think about this? Is it good or bad option?
Bad option
I think
because you've already
bad
moved on.
option.
Why?
Because you've already moved on.
judging patient. We judging.
I need to hear one by one. Yes, doctor, then the other doctor, yeah.
You're correcting mistake by doing more mistake.
How come?
You're saying you're pointing toward the language barrier that can be insulted to the patient as well.
Okay. Okay, good option. So we are not taking E as a good option now. Leave that for now. So far, we have just C as a good option. Okay. If after the word round, email the registrar.
Sorry to interrupt.
Say it again.
I think E also because on the scenario there is no mention that there is language barrier.
Oh, okay. Okay. So you're assuming things basically. Okay. Okay. If after the word round, email the registrar supervisor about the comment. What do you think?
I think
I don't think this is a good option because first of all, it'll create an issue between you and your registrar. You don't want to like without addressing it to your reg straight away. So I personally.
So is it good or bad?
It's bad.
Bad option. Okay. Do we all agree?
No, I think it's a good.
I think
Why?
it's good, yeah.
Because we need to highlight his supervisor so he can speak to him.
Okay, so we are, let's say 50-50. I will move on and come back to that.
Oh.
So report the registrar to your consultant in your break. What do you think about this?
This is not good.
This is
Why?
not good.
Because I have to speak with him directly first, and then after that, if nothing happened, then I have to escalate to the senior.
Okay. Yes, Mahmoud Osman.
Assalamu alaikum. Report is an ultimate action. So I need to reflect first on for the senior. Then it's not appropriate to report a senior. It will affect your inter-colleague relationships. Yes.
Okay.
Well, actually, I think it's a very good option.
Why?
Because here in this example, it doesn't let you choose to rank. It just makes you choose the best option. So first, I would speak to the registrar between me and him, and if it didn't resolve the issue, I would go to the consultant or his supervisor.
Okay. Okay.
I think it is also bad because on my break I don't need to work or to do anything on my break.
Okay. So let's stick to the raising hands so I can see the candidates and ask them. So I will take just two, Muhammad Sami and Vikram and Imtinan, and then we'll move on. Yes.
Yes, doctor. Thank you. I think a report, which is G. In my opinion, I must do it because racism and bullying and these things, no point of waiting. So it's like a red flag. So the report is 100%, in my opinion, must be done.
Okay, thank you so much. Yes, Dr. Vikram and Dr. Krishna.
Yeah, I think it's also you're delaying the action by emailing, whereas report is more immediate.
Okay, very good. Yes, Dr. Krishna.
So in my opinion, it follows the hierarchy chain. So if your registrar does a mistake, then the ultimate responsibility would be the consultant.
Very good. Very good addition. Very good. Thank you so much.
And then
I miss you, Dr. Imtinan. Sorry. Last one. Yes, Dr. Imtinan.
Yeah. I should report him to his consultant, not to mine.
Okay. Okay. Very good. So we are almost agreeing to report him somewhere. So we'll take this. What about H? Document the incident in the patient note in social history. Anyone?
No, this is not appropriate because we can't.
So,
yeah.
Dr. Najat, I'm really sorry, but it will be better if you are just raising hands. So you can talk
I'm
now.
very sorry. I'm very sorry.
Yes, tell me. Yes, Dr. Najat, then Faisal.
Oh, okay. So this is not appropriate because we can't, like, this discussions is written on the notes, on the medical notes.
Okay. Okay. Very good. Yes, Dr. Faisal.
Yes, I think there is a proper channel for reporting like DETEX. and then we should not report on the
Okay,
patient notes.
very good, very good. So the actual answer is C. I'm sorry, I need to move on. I'm sorry. C, E, and G. C, E, and G. How come? Now we have excluded A and we knew why. We excluded B, we knew why. We excluded D, yes. E makes no sense for now, leave that. H makes no sense. The patient notes should be for the clinical things, plan of management, whatever. But if I have something, let's say admin work, something, as Dr. I think Faisal said, clinical incident, there is specific channels, official, to report that. It's not the patient note. It is not the patient note. The patient note about the factual clinical things. You have to understand that. So I've been left with E, F, and G. Okay. F and G, if you saw something like that, this is like a gift for you. Why? In the questions 3 best of 8, you can never ever duplicate your effort. Now, F is a way of reporting, and G is a way of reporting. Both are escalation. You cannot escalate twice. You cannot escalate twice. If you are doing one thing, this one thing should add a new point. That's the 4th or 5th skill in one question. Now, you have to learn that. You need to choose 3 options. They form an answer together. They integrate each other. One answer might be missing something, that's fine, but is not incorrect. It's good, but missing something. The other answer will support that answer. For example, say nothing now and tell him, that's good, but you need to report him. The doctors who said this is a zero tolerance, we need to report that, that's 100% correct. We have very few things, I've mentioned them, you need to report them no matter whatsoever. Yes, it's nice to speak to him privately. That's why when you speak to him privately, you are not explaining, you are not giving him any chance. You are telling that was inappropriate, very blunt. But you have to report at the same time. Why? Because racism, bullying, derogatory remarks, there was zero tolerance. No one should ever practice that, ever. So I gave him zero chance. I'm just escalating immediately. Talking to him, no problem, privately, but I need to escalate that. Even if he did it just once, even if he was stressed, this needs to be reported. No patient or colleague needs to be subjected to that racism at all. So we need to report that. I have F and G. In the real exam, if they are giving you 2 actions, they are doing the exact same concept, escalation, you choose one and discard one. That's a gift for you. So now between F and G, which one would you choose? Email to his supervisor or report to my supervisor? Someone mentioned something very nice. There is a hierarchy. If I'm escalating to my consultant, which is practically his consultant. He is my registrar. So if you know basics of hierarchy in the NHS, you will know your consultant. I'm not talking about supervisor. Your consultant, the consultant who is leading the ward round, will be his consultant as well because you are on the same team. But his supervisor will be different from your supervisor, might be. So instead of going to his supervisor, it's better to go to your consultant. This is number 1. Number 2, it's faster. There's something somehow urgent. You need to be quick. It's faster to report him to your consultant than to email. That's a very valid point. So G is superior to F for 2 reasons. Number 1, your consultant, which is his consultant as well. Number 2, reporting directly is much faster than sending an email. Might be overlooked. Yes, Dr. Vikram?
I have a quick question for G. If it was, say you were an addition on a ward round and the consultant wasn't the same for your registrar and you, then would F be the better option?
If the consultant was attending the meeting.
So if the if the registrar wasn't on your team for whatever the scenario was, would the appropriate option then be to raise it to his supervisor?
It will be very difficult and they will never bring that. The exam is difficult but not unfair. So they cannot make it equivocal. There is 1 point here, 1 point here. They might do that in ranking and you need to rank them, but not in 3 best of 8. Why? Because you will be just in the middle. 50% is going with this answer and 50% is going with the answer, and they will not do that. They will give you hints. If you understood them, you will just pick the right answer.
Okay,
So
thank you.
now G is better than F for 2 points, but they will not make it one here and one here. It will be difficult, unfair. How will you choose? That's why either F or G, and G is superior to F, you cannot duplicate your effort. So you are doing a G, you are doing C, that's why F will automatically be cancelled. That's why E. E for me, it makes less sense, but the only potential option. I can never go for A, neither B, not D, not H, and F has been cancelled by the effect of G. So that's why E is a good answer here. I wouldn't say good, but the most potential answer here. Yes, Dr. Rania. Yes, Dr. Rania?
Yes, sorry. How did you assume that the language barrier was the right answer, despite that nothing has been mentioned in the...
That's the limitation in E, but assuming the language barrier was the reason is less harmful than apologizing on behalf of someone, less harmful than stopping the war down, lesser. Do you understand what I'm saying? I'm saying E, if it's ranking, I will keep E maybe number 4, but I need to pick third answer, and the exam is tricky to a point that you need to pick an answer. So the only way, what I'm saying indirectly, the only way to solve a question like this, is to know why every single answer is incorrect. This is the only way. I confidently say A is very, very bad, B is very, very bad, D is very, very bad, H is very, very bad, against a major concept in the NHS and GMC. And F is duplication of G. It's just like I'm doing nothing. I cannot do nothing. That's why the only potential answer is E. I'm not happy about E. It's not the best professional response that I could do, but it's the most acceptable one. The one I'm trying to say.
Thank you.
Yes, Dr. Mohammed?
Yes, thank you. Dr. Qusay, please, option D, reflect on the whole experience. What exactly does this mean? What's the meaning of reflect?
Here, if you are working in the UK, you will have a portfolio. If you are F1, F2, if you are trust grade doctor, you will have a portfolio. In that portfolio, basically you are logging on what you have been doing during your academic year. And this will be looked by your supervisor, then by the appraisal board. They will say, yes, you are qualified to finish this year to go for the next year, for example. So reflection is writing something that, oh, I've learned something, that experience taught me this. Next time, if I saw something like that. So something just for your own benefit, to show that I'm a reflective doctor, I'm learning from what's going on. I don't need to do mistake by myself to learn from that, something like that.
Okay, thank you. So, sorry, more addition. So, what, even if I reflect in my portfolio, so what's the advantage? What's the benefit?
The benefit is you are learning from this encounter. You as a doctor trying to get better by yourself. And this is very critical character of a junior doctor in the GMC NHS. You need to show reflective behavior all the time, something like that.
Whether clinical or non-clinical.
Yes, definitely.
Thank you very much.
No worries. So, how would you study the SJT? This is a live example now. You need to analyze. You start doing analysis. This is the only way forward, I'm telling you. So in that question, we had so many concepts. One of them, the apology. Now we have analyzed no apology on behalf of someone and no apology in the presence of the sinner. Let's say the sinner. Let's keep it this way. The one who did the mistake. I cannot apologize if he's present. How did I come to that? I analyzed the situation. I've seen so many apology question. He apologized in this, but not this one. Why? Because the one who did the mistake was there. I need to make my own curriculum. You understand? So now, under the subject of apology, I knew now no apology on behalf of someone, no apology in the presence of the sinner. This is the only way forward. Racism. I need to apply zero tolerance. I need to challenge that no matter whatsoever. That's why I'm talking to him. I'm saying very blunt, unacceptable word. it's inappropriate without even explaining. I'm immediately reporting, escalating even without waiting for him. This is about racism. It's not applicable for breaching confidentiality or any potential mistake that's been done because of lack of experience. I might breach confidentiality because I don't understand. I might go against the patient autonomy because I don't understand. But racism, theft, this is nothing to do with understanding. This is your own morals. Zero tolerance. Okay, now I've learned word round means or representing patient safety. I cannot mess around with that. But let's look to the right side of the slide, which is more important for me. Now I've acquired a skill to differentiate between ongoing and committed, sin or mistake or encounter. If something ongoing, I need to challenge and stop that by all means, in expense of anything. Especially if we are talking about major things like racism, bullying, I need to stop that. You will face questions like this, telling you overheard your colleague or the nurse is talking back to the patient. She is talking, ing, talking. You need to stop that. If she already talk, no, you can address that privately. And we got that. I don't want to repeat myself. So we acquire the skill, ongoing versus committed, something already done. That will represent, in this question, will represent the patient care versus stopping racism. If they just modify the phrase, they're telling you he was talking to the patient and you are in the middle of that situation, now you need to stop that. You need to challenge that. But professionally, by asking him, taking him aside in the middle of that racist encounter. You cannot shout, of course. You cannot raise your voice. You can just ask him, can I talk to you? Immediately. Even if that means you are stopping the word round, because you are adding something, you are stopping an actual harm now. Okay? And the patient care is something potential. There is no actual, unless they are make it very, very complicated by telling you there is an arresting patient or patient deteriorating. Now you have immediate patient safety and immediate harm to one patient. And they will never do that. So it's patient care versus stopping the racism according to the situation, the skill. It's ongoing or committed already. So I need the other skill. I need to apply the best course of action now. If I'm reflecting, that's good. But if they say reflect on your break, that's very nice. But if they made it just vague, I need to understand where am I now? I am in the middle of the whole round. I cannot now do reflection. That makes no sense. So the best action now, unless they specify the time. Again, no duplication. You cannot duplicate your effort. If you are duplicating, basically you are saying I'm doing nothing. You cannot do nothing. To a point that you might go for an option which is less potentially appropriate. It might be appropriate, it might not be. So it's 50-50. You might go for that rather than duplicating yourself. These are very important skills you need to learn. You need to study the SJT this way. This is the only way. Okay? So the
Dr.
SJT
Qusay,
technique, yes, sorry.
so if they say reflect at the end of the round or at the end of the day,
I
so
will
it
take this definitely over language barrier and whatever. I will take this
exactly.
blindly.
Yeah.
Okay?
Yeah.
Okay. So practically speaking, how would you study for the SJT? Because it's the difficult part. And what are the resources? Number one, the analytical study. You have seen an example. How do you do that? That's time consuming, brain consuming, to be honest. But you have no other way. You need to do that if you want to go to radiology. So what are the resources that you need to apply the analytical study on? You have a foundation paper. There are 4. And again, I will give you a link at the end of this presentation to access them. So you have 4 foundation paper. You need to master them. You must analyze them the way that we have done. If you want to extend, you might go for Oxford and book for SJT. That's very good and up to date. I wouldn't say up to date. I would say partially up to date because it's 2022 and there is some GMC update in 2025. However, it's a very good source. And there are some mocks. They are online, but they are like let's say previous exams. They are very helpful. They might be incorrectly answers. You need to be very careful. I'm telling you. The one who answered them answer some of the question incorrectly, unfortunately, but they are giving you the taste of the real exam. They are very important. You need to update yourself with the GMC Good Medical Practice 2025, January. That's an online. Again, I'll give you a link for this resource as well. That's very important. And please, 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 if I'm giving you one advice, avoid any online question bank, because you will after some time, let's say 2-3 months, you will master their own methodology, which is very good, but it's not going to help you in the exam, because the SJT is something very subjective. It's not like an evidence-based science. What you think is appropriate for me, I don't think it's appropriate. You need to learn the mentality of the exam writers, which is the foundation paper. If you are going to extend, I really suggest you study more after finishing the foundation paper and the Oxford handbook, but go for books, because books, they follow strict principles and rules, but the online question banks, you don't know who's writing what, and so don't do question banks. They will really just misconcept your concepts. They will really confuse you. So don't do the online question bank in SJT. If you want to do them, they are very specific one. They are good. I wouldn't say good. They are less harmful, but do them after you really master the foundation paper, Oxford, and the other books. So you have a very good base. You know what is good, what is bad. And I'm telling you, they answered some of the questions 100% against, contradictory to the foundation paper, which is the style of the exam. So they might be very, very harmful. Okay, so I'm giving you actually one of your colleagues, Dr. Mihad Adel. She meant to join us here, but she is sharing her experience with SJT. She sat for the exam in September and she scored 275 in SJT, which is very high score. So I've asked her to share her experience. I will leave you to read the experience while I'm answering some questions. You can read her example. Yes, Dr. Aditi and Dr. Muhammad. I think Dr. Muhammad, yes, and Dr. Tasneem. Yes, Dr. Muhammad.
Sorry, Dr. Qusay, I forgot to.
No problem, no worries. Yes, Dr.
Sorry.
Tasneem.
Yeah, I wanted to ask regarding foundation paper, Oxford, and mocks. What mocks you are mentioning to?
Maybe I will read that in the chat box.
Okay.
So basically, you need to study very hard for the SJT. You need to analyze a lot to have let's say like a base of information. Then you can go on for the other books and things like
Sorry,
that.
Dr. Qusay, what is the 250 book?
There is one book called 250 SJT case. This is the name of the book. It's a little bit old, outdated, because it has been published 2013, before the MSRA being created anyway. But the one who created that book, the author, he is the same author of the AKT, SJT. AKT is the exam of the GPs. They have the SJT part as well. So he's the same author. It's very good, but outdated. There are some concepts are not up to date. Like for example, in that book, they don't believe the nurse practitioner could see patient. That's very unsafe, which is not the case in the DMC anyway. So it's a little bit outdated, but they have so many nice concepts to learn from. So you need to be very careful when studying them.
Thank you.
Okay, let's talk about the clinical. This is like a real gift for you. I'm surprised this time. Why? Let's talk about the clinical generally. The clinical exam is more integrated. It's a GP style. It's clustered. So they ask you 6-7 questions about immunology, 6-7 questions about SLE. It's really like that. And it is like generic SHO GP level. And for me, it's more straightforward and easier to grasp. And they're asking you about cardiovascular, respiratory, muscular. You know what clinical is. We all know that. So it is like a generic knowledge of your clinical subjects in your medical school, and people usually tend to score higher in that. So I've seen 10 results of September exam taker. These 10 candidates, I've seen their results myself. The average score of them is 307, which is very, very exceptionally high. The average. So some of them, they scored 312, 311, some of them 299. Why I'm mentioning these 10 people? They studied from the same resource. So please stop wasting your time in the clinical part. Just study from that resource, because I'm telling you, 10 different people, they don't know each other. They scored in average 307. That's exceptionally high. So this is a very, very reliable resource. I'm not talking too much about that. I'm leaving your colleague, Dr. Fatima Osman. Gratefully, she agreed to share her experience with clinical part and that resource, and she'll tell us more about it. I would love if she can join us now. Are you here, Dr. Fatima? I'm not sure. I'm not sure. I'm not sure if she's here or not. So she scored 303, and she studied just 8 weeks. 8 weeks, I think 8 to 10 weeks for the clinical. So I thought this experience is really worthy to be shared with you. That will give you a lot of relaxation and reassurance. So if you are here, Dr. Fatma, do you want to share your experience? So I don't know if she's here or not. However, let me talk you through her experience. So she started studying for the clinical part in July, and the exam was in September, as you know. So it was like 8-10 weeks maximum, and she scored very, very high. This is like 1.5 standard deviation above the average. And I think, yes, go ahead, Dr. Fatima. Because the people want to hear from you.
Yeah, hello everyone. So first of all, I want to mention that thank you, Dr. Qusay, because he gave me some advice for my exam, and I had only 40 days to prepare for the clinical part. And Alhamdulillah, I scored 303 on the clinical part. So it was my second attempt. In my first attempt in January, I wasn't fully prepared, and I wasn't aware about the MSRA exam, really, but I scored like 274 at that time. And during this time, I just changed my strategy completely. I prepared for 40 days, as I mentioned, and I was studying at least 7 hours a day. And during that period, I was totally free from any other commitment. So all the time, I was studying only. And I spent most of my time at the library from 9 a.m. till closing. So regarding my main resource was revised MSRA and Samsung mocks as well. So regarding the revised MSRA, I use it as my base question bank for the clinical part. I read all the system notes. So I start with each system, reading the notes and then doing all the questions. After I finished the first read, I just did the question banks again. And after that, I did the mocks twice, one by myself and the second time with my study partner. So we were discussing each question. And I think can help anyone because when you have study partner, even for the clinical part, each person will have like they will study from other different clinic question banks, so they will be like having a lot of different information as well. So regarding the Samsung, and I think Samsung mocks have like the question from the exam, it was 80% from Samsung mocks, and there's like only 14 mocks in Samsung for the clinical part, of course, and it was incredibly useful. So I did it each of them like 3 to 4 times, and I tried to memorize them as much as possible. So even in the exam, I felt like it is Samsung mocks. Only 20% of the question was little bit news, and and the other part it was from the revised MSRA as well. So yeah, so this approach worked really well for me. It might not suit anyone or everyone, but I hope it gives you some idea from your own preparation. And
Actually, thank you so much, because scoring 340 days, that's really something almost, for me, it's almost impossible. So now, in the clinical parts, we need to take the stress away. Now we have very valid, reliable resource. You have seen one of your colleagues who studied just in 40 days, scored very high. And this is something, not just a personal experience. I've came across 10 applicants. They all scored 300, around 300, by studying from the same resource. So now you know the two resources. You need just to master them and give the most of your effort and your time for the SJT. Thank you so much, Dr. Fatima. Thank you so much for sharing those.
thank you, Dr. Qasai. Thank you.
Yes, Dr. Tasneem?
I just wanted to ask Dr. Fatima, which did she depend also on the SGT from Samsung and revise for
Well,
the
actually,
SGT?
yeah. So actually, my SGT marks it was not that good. But the most of people who used the revised MSRA SGT part, they mentioned it was very helpful as well. But I don't know actually.
Okay,
Sorry.
no problem. Thank you very much and
Thank you.
congratulations.
Thank you.
So much, Dr. Fatima. Yes, Dr. Rania?
One question for Dr. Fatma. Sorry, do you think that revised MSRA, the mock exam is the same as the question bank? So if I did the mock exam, no need to read the question bank, or what do you think?
No, I think there's high yield question in the like in the mocks, because in the exam there were like copy paste question from the mocks of revised MSRA. So I think it's better to go through it twice. It's only like 7 or 6 mocks only.
Okay, so going through the mock exam can at least shorten the duration of reading, given that we are working. This is why.
Oh. Well, this is very hard question. I don't
Yeah.
know.
It's okay.
Yeah.
I didn't mean it to be
No, it's fine.
Thank you anyway. Thanks.
You're welcome. Good luck.
Thank you so much, Dr. Fatima. So let's give some hypothetical examples. Dr. A, who scored 300 of so I've really mixed them, sorry. I meant 305 in clinical and 215 SJT, which is the classical scenario. So the total score would be 555. So you are most likely will get a radiology offer, because the radiology cut score last year was 545, the year before was 555, something like that. So classically, you need to excel in the clinical part, scoring 300 plus, and be at the average in the SJT, just the average. You will get a radiology. You'll be shortlisted, let's say. You'll be shortlisted to the interview, at least. So your mentality should be, I need to excel in the clinical. I need to be at the average of the SJT. But believe me, being at the average of the SJT, it requires very, very hard work. It's not an easy to score 250. It's not an easy. So Dr. B, who scored 218 SJT, this doctor excelled in SJT, made life easy for himself, and he scored 219 clinical part. So the total score was 570. He will get whatever he wants, anesthesia, radiology, ophthalmology, by 570. So Dr. C scored 215 SKT, which is average, but 218 clinical, which is good, but not exceptionally good. So the total score was 30. So no offer, no, has not been shortlisted for radiology. So even if you are scoring 250 in SJT, which requires a lot of hard work, and you are scoring 280 in clinical, that's not enough. What I'm trying to say, if you are aiming for radiology, anesthesia, ophthalmology, you need to excel in clinical and to be at the average of the SJT. If you are doing better in SJT by scoring 270, like Dr. Mihad, for example, that would be even better and easier for you in the clinical part. So let's update you. Yes, anyone asking any question? So let's update you about the last, let's say the most up-to-date cut scores.
Hey.
In the, yeah? In the previous round, September 2025, the psychiatry, they start to offer people from score 545, which is very high for psychiatry, but don't be misled by that. The number of the seats were really limited and the applicant number was huge. That's why. If you are aiming for that in round 1 next year, it will be easier. So the score will not be as high as 545. However, for the GP, believe it or not, the minimum score to get an offer for GP in that round was 537, which is very high score for GP. However, it went down up to 528 today. So today, with the third cycle or fourth cycle, the people who scored 528 in MSRA, they got an offer for GP. However, the anesthesia kept the cut score of 553. This will give you a clue about the competition ratio and the ratio between application and posts, because the posts are very limited in round 3 and the applicant number is huge. That's why the scores are going that high. So don't be misled. So what is the updates, the new prerequisite for you to sit for the exam? So usually you can apply, and even if you don't have the GMC registration, but by the time of the post, which is 2nd or 3rd of August, you need to complete your GMC registration. But now it's not the case anymore. You need to have full GMC registration before even applying. So the application window will start tomorrow. Before you start your application, you need to show the full GMC registration, which is something brand new this year. That will select a lot of people. I'm talking about myself, at least. When I first applied for IMT, I got the IMT. I haven't finished my GMC registration. I was on the process doing the PLABs. Then I came later on, but it's not the case anymore. You need to have the GMC before you apply. Now, this year, they limited the number of application. You have just 5 applications to apply. People used to apply everywhere, but now you have just 5 applications. If you are considering radiology, radiology is on application. Radiology North Island is an different application. So they are 2 applications. You have just 3 left. So you could apply for just 5 applications this year, okay? So how would you, to make it practical, how would you prepare? How would you make your plan? Now we have 10 weeks, exactly 10 weeks till the 1st of January. If you are writing the exam the first week, it's 10 weeks till the exam. If you are writing the exam, you've been lucky and you're writing the exam the 2nd or the last day of the exam, you have 12 weeks. So it's ranging between 10 to 12 weeks. How would you spread these weeks? However, I've divided them into 3 phases. Phase 1, which is 4 weeks, you need to go on a baseline pace, which is slow pace. Don't worry. The aim is to analyze the questions. You are creating your own curriculum. You are teaching yourself. You are just deeply learning now. This will take 4 weeks. Go through the foundation papers, Oxford if you could, and what could be helpful to study in group, because really absorbing the SJT for the first time, analytical way might be really hard and difficult, and you might just give up. So go for study groups, study with your colleagues, but you need to study alone as well. Don't just rely on the groups. This will take 4 weeks. Now you have 6 weeks minimum. Here, phase 2 comes into place. In phase 2, which is 4 weeks as well, you need to study as much as you could after establishing the concepts. 4 weeks for the concepts, 4 weeks to do more questions, study more, study from other books, I would not recommend you going for online question bank, but if you are doing that, you need to be very picky. And the aim for this 4 weeks is to get border ideology and exposure, because in the real exam, they might bring crazy things. So you need to have exposure. You don't need to be shocked in the exam. Oh, this is the first time I encountered this. That will consume a lot of time because you will feel, oh, I might get it right. Let me spend more time. And then you will miss 2-3 questions at the end of your exam. So you need to get as much experience as you could. This is phase 2. In phase 1, the aim is different. You study less, you study slower, and you understand more. And in phase 2, you do more questions. In phase 3, you're just doing some timed mock. And I do offer online free mocks as well near the exam. And you need to read your handouts. You must summarize, and you need to read that in the last 2 weeks to do the light job and acquire more like exam skills. How would you finish on time? How would you not miss questions? Something like that in the last 2 weeks. So just try to divide your 10 weeks this way. So the exam day, you need to be at the top of the pace. You need to finish on time. And this will happen if you specify the last 2 weeks just doing online mocks. Not necessarily online, you can just do time mock. And during the exam, you flag the tough questions. Don't stop because you are losing one question at the end. Flag it, go finish the exam and come back to it. And don't forget to answer all questions. Don't leave any blank questions, please.